Welcome to the webinar.
The speakers are Professor Stefano Salvatore and Professor Karram. Professor Stefano Salvatore, Italy, is responsible for the Urogynecological Functional Unit, IRCCS, San Raffaele Hospital, Milan. Professor at Vita and Salute University, Milan. Vice President of European Urogynecological Association, EUGA. Professor Karram, USA, is Director of the Fellowship Program, Female Pelvic Medicine and Reconstructive Surgery. The Christ Hospital and Professor of Obstetrics and Gynecology and Urology, University of Cincinnati, USA. We hope you enjoy the conference.
Good afternoon. I'm going to start off by talking about the therapeutic area of vaginal atrophy. Of note, the terms that we've used in the past, specifically vulvovaginal atrophy, to describe these various symptoms have recently been changed to genitourinary syndrome of menopause. And this is a terminology change that was done by the North American Menopause Society in conjunction with the European Menopause Society. So we'll go back and forth with these two terms, but basically what we're talking about is a myriad of symptoms that occur in a woman as she loses her circulating estrogen. This obviously most notably occurs in the natural transition of menopause, but also certainly occurs if someone loses their ovaries via surgery, in patients with breast cancer in which they're placed on medications that block estrogen. The symptoms that we're talking about specifically are vaginal and vulvar dryness, burning, dyspareunia, and a variety of irritative lower urinary tract symptoms, specifically dysuria, urgency, and frequency. If we look closer at what is happening physiologically and morphologically, we basically see a variety of changes in the pelvic floor at large. There's a reduction of blood flow and vaginal secretions, which results in vaginal dryness. You get morphologic alterations, a change in the maturation index, and more notably, a significant histologic change in the stratified squamous epithelium. And then you get a change in the milieu of the vagina, in which you basically start to lose vaginal lactobacilli. The vagina becomes more alkaline. There's a loss of glycogen, and these changes are very important in some of the protective mechanisms, most notably a protective mechanism for development of urinary tract infections. If we look histologically at what happens to that stratified squamous epithelium, on the left side of this slide is a typical postmenopausal vaginal biopsy. You can see here the stratified squamous epithelium is very thin, it's poorly vascularized, there's very little collagen, very little there's a loss of papillae. On the right-hand side is a biopsy in someone who is premenopausal, and again you can see the tissue is much healthier. There's large papillae, a lot of glycogen, a lot of blood supply. And I ask you to keep this picture in your mind because as we move forward in this presentation, it's tremendously impressive to show how this fractional CO2 laser not only improves these symptoms, but also creates histologic changes very consistent with what you'd see in someone that is premenopausal. So if we look at the prevalence of genitourinary syndrome of menopause or vulvovaginal atrophy, it's really impressive to note how many women are suffering with these problems. You may or may not be aware that the largest segment of our population growth-wise in the US is the female above the age of 60. And approximately half of postmenopausal women will ultimately develop significant symptoms of GSM or atrophy within a few to 4 or 5 years of losing their estrogen. And also, very important to appreciate that unlike vasomotor or systemic symptoms like hot flashes that occur when a woman goes into menopause, the symptoms of genitourinary syndrome of menopause or atrophy don't spontaneously remit and commonly recur when hormones are withdrawn. So if you've got a patient that's got hot flashes, many times those will go away over time, or treating them with systemic estrogen for a short period of time will give you a long-term success. That doesn't happen at the local level in the vaginal epithelium, in that if you have a patient that developed these symptoms, they have to be put on hormones basically for life, or the symptoms recur. If we look at specifically when these symptoms start to develop, this is some data that Ibu Versi published over 10 years ago. And basically, in general, by the time a woman is 4 years postmenopausal, 50% of the time, they will start to develop what they perceive are significant quality of life symptoms of atrophy. Specifically, if we look at dryness, this study, again, over 10 years old, notes that by the time a woman is 3 years postmenopausal, almost 50% of these patients will complain of significant vaginal dryness. If we specifically look at various aspects of what is happening at a local level, you get a wide array of dryness, anything from mild cases to very severe cases where women say it almost feels like there's razor blades in her vagina. You get a loss of mucosal elasticity and pliability. And again, this initially can be just a slight loss, and in more severe cases, the vagina becomes somewhat stenotic and completely non-pliable. The pH, again, is altered. The pH becomes more alkalinic, and the more alkalinic it becomes, you get more of a change in that milieu that we talked about, and loss of lactobacilli, loss of glycogen. The rugations slowly disappear to the point that in severe cases, the vagina becomes very, very smooth. The color changes. You go from a light pink in mild cases to a white, deep, almost red color in severe cases. And finally, you get these petechiae, which initially are rare, and in more severe cases, they're very, very prevalent, to the point that the patient has bleeding whenever anything comes in contact with the vaginal mucosa. Of extreme relevance here is that a significant number of patients with cancer, most notably breast cancer, are really suffering in silence with these problems. And unfortunately, we have very little up till now to offer these patients. So these are patients who either have hormone-sensitive tumors or are concerned about taking any estrogen because they've developed a breast cancer. And there is a tremendous amount of controversy around the utilization of hormones in these patients. And even if the patient is told she can use hormones, many are very reluctant because of concerns of recurrence of her cancer. Specifically, breast cancer patients will have a significant problem with these symptoms, anywhere, as you can see in this slide, from a third to a half, even 60% of patients with breast cancer will complain of vaginal dryness, significant dyspareunia, as well as lower urinary tract symptoms. Breast cancer is extremely prevalent worldwide, specifically in the United States. In 2014, we diagnosed 232,000 cases of breast cancer. The good news is these patients have a good 5-year survival of close to 90%. The bad news is these patients truly are suffering in silence, and really up till now have had no real good therapy that is safe and efficacious. So to surmise, this is definitely a big problem. Again, we're talking about millions and millions of women that suffer from a variety of these various symptoms, and the amount of women suffering is rising at an exponential fashion, as again, this is the largest segment of our growth population. If we look currently at what we treat GSM or atrophy with, most notably it's estrogen. And estrogen can be a very efficacious therapy in certain women, but it certainly has its issues, and it's beyond the scope of this webinar to go into great detail. But again, certainly patients with breast cancers, patients with other contraindications, thrombophlebitis, and a variety of other systemic problems that may be impacted in a negative way really limit our utilization. On top of that, compliance and cost are also a significant issue with estrogen. The only oral medication approved for vaginal atrophy or dyspareunia related to vaginal atrophy is a medication called Osphenia. This is available in the United States. It's a unique compound. It's called a SERM. It's a selective estrogen receptor modulator, meaning it is an estrogen agonist at certain parts of the body and an estrogen antagonist at certain parts of the body. Again, it's an oral therapy. It usually requires at least 3 months to have any efficacy with it, and there's also some of the same concerns that we have with estrogen. Short of those two therapies, we're basically left with vaginal moisturizers and lubricating jellies, as well as a variety of botanicals that really have no data or validity behind them. Specifically with estrogen, if you're going to have any chance at treating the atrophy, you really need to go to a local estrogen. Systemic estrogen, most of the time, will not give you the effect on the local tissues that you'd need to take care of these symptoms. So when we talk about local estrogen, we're basically choosing between 3 modalities. One is an S-string, the second is a tablet or VAGIFEM. Most of us, however, would prefer a vaginal cream. And again, there's challenges with the cream. If a patient still has her uterus, you have to be concerned about the stimulation of the uterus by the estrogen, concerns about breast cancer patients, as well as the compliance issue and the messiness of it. Finally, it's technically challenging to get estrogen to actually treat the entire vaginal canal. It's inserted in the distal vagina, and most of the time it stays in the distal vagina. Lubricants and hydration treatments are really what most women are left with, and as I alluded to in the previous slides, again, these really aren't treating anything. They're just trying to put a Band-Aid on a very big problem, and that's very unfortunate. So, in summary, I think I've hopefully stressed the point that this is a very prevalent problem impacting millions and millions of women worldwide, and there's a tremendous unmet need for treating these symptoms in women. With that said, I'm going to turn things over to Professor Stefano Salvatore. I was fortunate enough to be introduced to this therapy approximately 18 months ago when I visited with Stefano at San Raffaele Hospital in Milan. Stefano has been involved in this therapy with his team from the inception numerous years ago, and it's with my great pleasure that he's going to talk a little bit about the therapy and his experience.
Good afternoon. Professor Karram illustrated the importance of vaginal atrophy as a clinical condition, gave us an extensive overview of the available treatment for this. I'm now going to introduce you a novel therapy for vaginal atrophy based on the use of intravaginal fractional CO2 laser called MonaLisa. I've been working on this for the last 5-6 years, and this procedure was first started in the San Raffaele Hospital in Milan, where I actually work. So my talk will cover the start of the procedure, the mechanism of action in the local tissue of CO2 laser, and the scientific publication we managed to produce so far. It all started in 2009 when I met a friend of mine who is professor in dermatology, Nicola Zerbinati, who tried to, in a way, win my skepticism about the use of laser in the genital tract for vaginal atrophy, showing me some literature that was very well known in dermatology, showing how CO2 laser can improve a lot of dermatological conditions, in particular atrophic conditions and scarred conditions. And the mechanism of action of CO2 laser in the skin has been very well known, and it started with this publication in 2003 describing how CO2 laser with a heating temporary process may change the cellular metabolism in a transient way, through some proteins called heat shock proteins. And particularly heat shock protein 70 and 47 are crucial factors in stimulating the production of the TGF-beta, that is a growth factor, important not just for the inflammatory body response, but also for the fibrogenic process. The TGF-beta, in fact, stimulates the fibrocytes to become fibroblasts and produce new collagen and extracellular matrix. In order for all this chain of events to occur, we need to wait up to 30-40 days. On the basis of this background, together with the laser manufacturer DEKA, we decided to try to explore in a way the possibility of treating an atrophic condition in the genital tract using some vaginal probes that were prototypes at that time, as you can see in this picture. At that time, we didn't know anything regarding the settings, the safety in a way, and the effects on the vaginal wall. And therefore, we decided to carry out an ex vivo study, including women who were submitted for anterior vaginal wall prolapse repair. And we decided to treat one side of the vaginal wall with 5 different settings. In the part of the vaginal wall that had to be trimmed at the end of the prolapse repair, and we used the contralateral part as control. In this study, we started cooperating with Professor Alberto Caligaro, who is an eminent professor at the University of Pavia, and who is professor of histology, who gave us basically the right interpretation of what happens in the vaginal wall after fractional CO2 laser. On the left top-hand side of this slide, you can see a control sample showing an atrophic vaginal wall with a thin epithelium without the presence of papillae, with a very, I would say, thick lamina propria. Accordingly to the 5 different settings that we tested, we eventually decided that we managed to demonstrate an effect on the vaginal wall, and we were at that time very much focused on the effect that we managed to produce in the lamina propria. Lamina propria lies just below the epithelial layer, and we can see at the right top-hand side of this slide that there is an increase in the extracellular matrix of the lamina propria. There are formations of new vessels, and there is a transformation of fibrocytes to fibroblasts, as is demonstrated by this string that are attached to the cellular body. At the bottom of this slide, you can see here an electronic microscopic picture of the new collagen that has been produced by this activated fibroblast that gains a trabecular network shape that in a way is very similar to the collagen that is present in fertile age of women. This is an electron microscopic image of a fibrocytes becoming fibroblast, and you can see at the top right-hand side here that the nucleus is pycnotic. That means that the DNA is replicating. We can see ribosomes here at the membranes of the Golgi apparatus, and we can see mucopolysaccharides in the cisterna that are then secreted in the lamina propria. On the basis of these results in the ex vivo study, we decided to carry out observational clinical studies, but before showing you the results, I think it's appropriate to give you an overview of the mechanism of action of the CO2 laser, and for this reason it's my pleasure to introduce Alessandro Bizzarri. He is a representative of the DEKA, that is the manufacturer of laser, and he's in charge of with the North American market for laser for DEKA.
Good afternoon, everybody. I'm Alessandro Bizzarri, and I wish to welcome all of you for joining us in this webinar. I'm here to give you a brief piece of information regarding the technology behind this procedure, and to give you actually another very brief piece of information regarding the company DEKA. DEKA, as you can see from this slide, is a company that has been producing lasers for quite some years. In fact, the company started in 1991 to produce and market lasers for many different medical applications. As you can see here in this slide, applications like gynecology, dermatology, ENT, urology, plastic surgery, and dentistry. Even though these are not the only, let's say, applications, so what we manufacture and sell in the company is not limited to these fields only. DEKA today introduces to the world the first laser that has actually been developed, designed for this particular application. I mean, for the treatment and prevention of vaginal atrophy. So it is not something that was taken and from our production and adapted to this particular vaginal atrophy procedure. It is instead something that was developed for this particular application. The laser that is at the basis of this treatment is a fractional CO2 laser. I guess most of you are already familiar with this word fractional. That means that we treat only a portion, only a fraction of the tissue, and we leave a great deal of the tissue spared, untouched. And in this way, of course, we have a less invasive treatment, less aggressive treatment, and of course better recovery, quicker recovery, and therefore shorter downtime. DEKA started, let's say, this market of fractional CO2 lasers in 2008, and so this particular laser, the Smart Sight Quadro, that is at the basis, that is the laser used for this particular procedure, is the latest evolution of these fractional CO2 lasers that the DEKA company started producing now 7 years ago. Again, the Smart Sight Quadro system is a radio frequency excited CO2 laser source that has been designed in a way to feature an exclusive pulse shape design that is able to generate many different types of pulses, and every pulse is specifically designed for treating different applications, particularly for this MonaLisa Touch procedure. The laser delivers the so-called D-pulse or DEKA pulse that has been really designed for the best, the right interaction with the vaginal mucosa. The DEKA pulse is made up of two different parts. One part at the beginning, the initial part of the pulse, that is a kind of part that is mainly dedicated to perform the ablation of the soft tissue, so to open a kind of aperture in the tissue, and the second part that we could name the tail of the pulse, that is instead the one mostly dedicated to deliver the heat, the laser energy, that is the heat to the tissue, and create coagulation in the tissue itself. to deliver the laser energy, so to operate the laser, of course, users will interact with the control panel of the laser and will will have the availability of a wide range of settings. They will interact with a laser that offer great versatility. That is what users, of course, need to adapt, to fine-tune the treatment to the different situations of the patients they will encounter, like in the event of severe atrophy or less severe atrophy. So the need to deliver either a more aggressive or a less aggressive treatment. For standard treatments, the settings we recommend are 40 watt in terms of power, a dwell time that is, let's say, more or less, I would say, mainly the duration of the second part of the DP pulse, so the tail of the pulse, that we recommend of 1000 microseconds, that is 1 milliseconds, and then a pitch, so the way of spacing dots, spacing the laser beam from one dot to another one of 1 millimeter. These are in fact the settings we recommend, and particularly, as you can see from the bottom part of this slide, the use of the DP pulse. To deliver the treatment, there are two applicators, two probes that are inserted in the vaginal canal, one that fires the laser beam at 360 degrees, the other one at 90 degrees. The difference between the two, well, probably with the one at 360 degrees, the treatment is delivered in a shortest time, but it's only a matter of a few seconds, because even with a 90-degree probe, the treatment, each treatment only lasts a matter of a few seconds, maybe less than 1 minute. This slide shows what happens in the vaginal canal. You can see the dots, you can see where the laser beam hits the tissue, so you can see what a fractional treatment means, because you see that there is a lot of spare tissue and only a minimal fraction of the entire tissue is treated. This is what happens in every pattern, in every place where we fire the laser, and actually the area treated is even less than 10% of the entire area. Same thing here. And in terms of what happens in each dot, in each place where the laser hits the tissue, we have an ablation, that is the vaporization of the tissue, of the epithelium in this particular case, and then an area that is that kind of darker ball around what is indicated as crater in the slide. That darker area, that is the area of coagulation. That is also one of the reasons why there is no bleeding in this procedure. Again, this same laser can also be used for other applications in terms of colposcopy, laparoscopy, surgery, and so forth. And a very last slide in my short presentation, a slide to show what we wanted to do, and we are happy, we are glad that we managed to do, introducing this particular device for delivering this particular procedure, the MonaLisa Touch. We wanted to give the smile back to many women all over the world that suffer many times in silence, like Dr. Karram said. Thank you very much for your time and attention, and I wish to hand you over now again to Dr. Salvatore.
Thank you, Alessandro. Now we're back to the clinical studies. After the encouraging results that we had in the ex vivo studies, in the ex vivo study we decided to carry out prospective observational studies looking at the clinical efficacy and possibly the histological changes of a fractional CO2 laser in women with vaginal atrophy. We also explored whether CO2 laser could improve quality of life and sexual function in another prospective study. Overall, we choose the same inclusion and exclusion criteria for all these studies, recruiting postmenopausal women with symptoms of vaginal atrophy and particularly vaginal dryness or dyspareunia that are for sure the most bothersome. We included from our menopause outpatient clinic women who had previous treatment with estrogen and they stopped them because of intolerance or because they didn't want to take them anymore. We also included women who had previous treatment with lubricants or moisturizers creams that were not happy with that sort of treatment. Another inclusion important criteria was the willingness to maintain an active sexual life. As exclusion criteria, we decided to exclude women with previous hormonal replacement therapy within 6 months since inclusion, or the same concept for the use of lubricants or moisturizers. We excluded women with acute or recurrent urinary tract infections and genital infections. Some of these exclusion criteria are not actually exclusion criteria for the clinical use of MonaLisa Touch, but we decided to include them because they may interfere with interpretation of the results at the end of the study. For this reason, we excluded also women with prolapse greater than stage 2 according to the POPQ system, or women who had previous reconstructive pelvic surgery. For all our clinical studies, we use basically the same study protocol. We decided to use, as we said, an intravaginal fractional microablative CO2 laser delivered by a specific vaginal probe. We arbitrarily decided to offer up to 3 treatments to our patients, with an interval of 30-40 days in between. As they were evaluated at baseline after the first treatment, the second treatment, and the third treatment, and the procedure was performed in an outpatient clinic without any form of analgesia or anesthesia. It was a very quick procedure with no adverse events, and women were then able to go home after the procedure itself. In terms of data collection, we decided to assess a very subjective symptoms like dryness and dyspareunia and dysuria with something that could in a way quantify the severity of the symptoms, and therefore we decided to use a 10-point visual analog scale that is widely used for many different conditions to evaluate subjective symptoms such as pain, for example, and women should tick on the left-hand side of this line whether that specific symptoms was not a problem for them, or they had to tick on the right-hand side whether this was a very severe problem. And this tool was used at any single visit of our patients. We also explored sexual function using a validated questionnaire in the Italian language. That was the FSFI. Just a little mention that in the Italian version, the cutoff value is not 27 as in the English version, but it is 29. That means that women below 29 have a sexual dysfunction. We also used a 10-point visual analog scale to assess in a way the perception of improvement or change in sexual function after treatment. And we also used a quality of life questionnaire, a generic quality of life questionnaire, the SF-12, that is composed of 2 major domains, the physical one and the mental domain. we asked our patients to fill in these questionnaires at baseline and after the last treatment. We also had the possibility to evaluate histological changes in 5 patients at baseline and after one single treatment. And I think that histological results are quite impressive, as Professor Karram already mentioned. At the top, this image at the top shows the picture at baseline of one of our patients, where you can see that the epithelial layer is formed by very tiny cells. At the bottom, you can see after one single treatment with the same magnification how the dimension of the papillae and the dimension of the epithelial cells changed dramatically, increasing in size. It's also impressive to see how the lamina propria is much more full of mucopolysaccharides as extracellular matrix compared to baseline. This slide shows some other histological results with specific stain for glycogen. On the left-hand side, you can see the same patients at baseline, and on the right-hand side, with the same magnification, you can see the changes again after one single treatment. And you can see how the dimension of the papillae increased dramatically, how the epithelial cells are engorged by glycogen, and the glycogen, together with the exfoliation, the physiological exfoliation of the cells, were then able to restore a normal lubrication, and they managed to change the acidity of the vaginal canal. This table shows the baseline characteristics of the first observational study. We included 50 women with a mean age of almost 60-year-old, with a good level of education, a normal body mass index, and some of them had previous HRT, 32% of them. Now, this table shows the results using all the tools that we adopted to evaluate our clinical efficacy. In the first line of this busy table, we can see the vaginal health index. That is actually a composite score. It's an eyeball evaluation performed by a gynecologist. It's a composite score that is formed by a scale from 0 to 5 of different variables, such as moisturizers, the clinical appearance of the vaginal wall, lubrication, and the pH. Below 14, the VHI score shows atrophy, and above a normal trophism. You can see that at baseline we included women with atrophy, and the more they had the treatment, the better was their VHI score. Now the next 5 following rows shows the mean values of the visual analog score for all these symptoms: vaginal dryness, burning, itching, dyspareunia, and dysuria. You can see the severity at baseline looking at the mean value of the 10-point visual analog score, and for each single symptoms we had a significant improvement, treatment after treatment, of each single vaginal atrophy complaint. For the sexual function, we had a significant improvement at baseline, at the end of the treatment compared to baseline, as well as for the generic quality of life questionnaire, both in the physical and mental domain. This table shows the characteristics of another group of women studied specifically for changes in sexual function. And the baseline characteristics were quite similar compared to the first study. And when we looked at the changes in the FSFI score, also in these women, we managed to demonstrate a significant improvement of sexual function at the end of the treatment compared to baseline. When we look at the perception of the improvement of treatment, we also found a statistically significant improvement. But what I think is one of the best results is that on entry, we had 74% of sexually active women that at the end raised up to 96.1%. So we managed to make almost a quarter of women return to a normal sexual life. And this graph shows what I've been illustrated in a table. In terms of sexual function, all the domains of the FSFI showed a significant improvement, desire, arousal, lubrication, orgasm, and these were secondary, obviously, to the improvement in the TC that we managed to obtain. Clinical efficacy was consistent with our first observational study, showing significant improvement in each single symptom, and also in terms of improvement in generic quality of life, we showed a significant improvement. So I was very skeptical at the beginning. We are working hard, and we've been working hard in trying to bring evidence, as suggested by Professor Deming, who is a Nobel Prize in Statistics from US in this field. Now, the evidence that we've been trying to produce is due to a common efforts of different people. Nicola Zerbinati as a dermatologist, Alberto Caligaro as a professor in histology, Rossella Nappi, we should have another picture here, who was the past president of the World Menopause Society, and she's expert also in sexuology, and all my team. And all together we managed to have some awards, such as the best abstract in the annual meeting of the Academic Gynecology in Italy in 2013. Umberto Leone, one of my fellows, was awarded with the second prize of the best clinical research project at the World Menopause Society meeting in Cancun. And we managed to publish a few papers in very prestigious international peer-reviewed journals looking at different aspects. The ex vivo study in the menopause. In Climateric, we had the first clinical observational study, and then the study on sexual function, and then we had an histological study in laser in medical science. It is my great pleasure now to introduce you Professor Miki Karram, who will show you the US experience and how they are proceeding there.
So as we finish up, I'm going to talk briefly about the actual treatment itself. And again, as Alessandro alluded to earlier, the treatment is an office procedure. It's a matter of a few minutes, doesn't require any anesthesia. It basically involves passing the probe to the top of the vagina, either irregardless of whether the patient's post-hysterectomy or still has a cervix, and then applying the laser energy basically at 2 points in the vagina, at 12 o'clock, and then you rotate the probe 45 degrees and treat the vagina at half-centimeter intervals throughout the entire vaginal canal. We've now treated 15 patients on protocol in conjunction with our colleague Dr. Eric Sokol at Stanford. He did 15 patients. We went off protocol in December of 2014. Since that time, I've treated probably an additional 60 patients. And I can say, hands down, that our data is right in line with the data that Dr. Salvatore presented. We can say without hesitation that the treatment is well tolerated, doesn't require any anesthesia, really has no downtime, and most notably, it's very safe. We, as well as the Italian experience, has not experienced any adverse event of significance. With that said, I'm going to show a short video, and this is an actual treatment in real time. Unfortunately, we don't have the ability to let you hear the sound, but again, this is a treatment that's being delivered in my office. The patient is obviously wide awake, has not received any preoperative medications or analgesics. Because this is a laser treatment, you can't use any lubrication, so the vagina is basically dry. Here's the 360-degree probe. We use the 12 o'clock position, which is where you see the tubing here as our landmark, and then the probe, after pass to the top of the vagina, is then rotated at 45 degrees. Here you can see the probe being placed in the vagina. This is probably the most challenging, if you want to call it challenging, part of the procedure, because the first treatment, the patients are usually quite dry, and you have to gently pass the probe to the top of the vagina. Once you get to the top of the vagina, you initiate the therapy, and as I mentioned, again, this is in real time, so this is exactly how long it's taking us to do the procedure. We start here, and we've delivered the laser treatment at 12 o'clock, rotate 45 degrees to 130, withdraw a half a centimeter, and continue in that same mode as we treat the entire vaginal canal. I'm talking to the patient throughout the treatment. She has no pain. Most patients describe the treatment as a feeling of a vibration. Again, any pain that's involved is usually on the first treatment, and that's due to the passage of the probe up through a very dry atrophic vagina. Here you can see we're getting to the distal portion. It doesn't have to be a very precise treatment, meaning you don't have to go to great lengths to make sure you're withdrawing exactly a half a centimeter. You want to basically follow these guidelines, and the treatment can be delivered in a very, very quick fashion. So in conclusion, as I said, we remain very excited about this treatment. We are now getting ready in conjunction with a variety of other centers to perform more research on this novel and new treatment. Our center will be working in conjunction with the Cleveland Clinic, Stanford, and Georgetown to initiate a randomized trial comparing this therapy directly to estrogen. We're also excited about looking at new treatments in the vulva, specifically lichen sclerosis, and also going to be doing some histology studies very similar to the studies that Dr. Salvatore mentioned that they've done here in Italy. At the present time, again, I can say that this treatment is quick and easy. Our preliminary results have been extremely impressive in regards to efficacy. We've seen basically data that is almost identical to what Dr. Salvatore presented, and basically have been very rewarded in delivering this treatment to many patients who had significant symptomatology and now can become sexually active, or if they were sexually active with pain, many of them are now experiencing.
The CO2 laser has an extremely important and undisputable advantage compared to other laser sources, and this advantage is the depth of penetration into the soft tissue to stimulate the recovery mechanism of the tissue itself. The CO2 laser wavelength, particularly the one that we use, that is 10,600 nanometer, is not too superficial like erbium YAG lasers at 2940 nanometer, and wavelength which is not affecting, for instance, in this particular application, the connective part of the vaginal mucosa, and it is not also too deep in terms of penetration like it would be for other near-infrared lasers like ND-YAG lasers or diode lasers, which could be dangerous.
So again, we are treating patients on a regular basis off protocol, but we also are initiating a variety of studies. We're in the process of doing a study that's going to be a head-to-head comparison of the MonaLisa to local estrogen. The study group that we've compiled is our group in Cincinnati in conjunction with the Cleveland Clinic, Eric Sokol at Stanford, and Sherelle Iglesia and her group at Georgetown. We're also very excited about potential applications for this technology on the vulva. Our initial observations in conjunction with discussions with Dr. Salvatore would seem to indicate that there's a high potential that this treatment may be efficacious for lichen sclerosis. We're going to be doing an initial cohort study on that. And also we're going to do some histology studies similar to what has already been done here in Italy to further study and understand this treatment. So we've treated and I have no issues treating patients who have had synthetic slings. Assuming the sling isn't exposed, I've treated numerous cases, as I believe Dr. Salvatore has as well. Personally, I would avoid treating anyone that has an exposed mesh. Someone that has a mesh that has been placed, a vaginal mesh or a mesh from a sacrocolpopexy, I think could be potential candidates. Personally, we don't have any experience to date treating those patients. Theoretically, I don't see any real concerns in that regard if the patient is atrophic, but I really can't state with any decisiveness about this because we've had no experience with it.
In the first observational study, where we recruited 50 patients, one of the symptoms that we evaluated with the temporal vision analog scale was also the symptom of laxity, and we had a significant improvement also in that. In terms of how we can measure that, it's quite difficult. There's not I would say, a normal value or nomograms for normal vaginas. What we tend to do is to be careful whether we can produce a better feeling in women with vaginal laxity when they are symptomatic. I know that this procedure is used extensively in some areas of the world, such as the Middle East or the Asian countries. Even with this indication, I think we should try to make in a way an objective evaluation of the effect of the CO2 laser also for this aspect. Regarding the external part, Professor Karram already mentioned how we are now trying to study the effect of CO2 laser in lichen, and I think we've got encouraging results. We're now about to submit a paper with histology and electron microscopic pictures of the effect of CO2 laser in the vulva tissue. We have improvement in the fourchette that may cause superficial dyspareunia in women with atrophy, although they might require, in severe cases, more than 3 treatments in our experience. And regarding vulvodynia, I don't have a personal experience. And there's another group here in Italy who is working hard on that, and hopefully they will come out with the results soon. I just know that it seems that it is quite encouraging, but I have no experience at all. Our first observational study included in our protocol in a way a sort of follow-up at 12 months, whether women should report whether they had a return of severity of symptoms, and on the basis of that, they were free to choose a further treatment or even a further cycle of treatments. And we have data at 12 months showing that looking at the mean value of visual analog scale, we have a very mild return of the symptoms that may not justify what we actually observed, that is the requirements by the patients themselves to have 1 or 2 treatments for the vast majority. Regarding this was in trial. In clinical practice, I have to say that sometimes maybe for being reassured or for being in a way safe that the duration will last for a long time, women come back sometimes earlier, maybe without a real clinical need, but differently from the study, in clinical practice we are observing this sort of attitude from our patients.
I think the only absolute contraindication would be an active infection. You obviously wouldn't want to do this in a patient who has an active herpetic outbreak or a patient who has a vagina full of warts or a lot of fungus and yeast. I think I would probably be a little reluctant in extreme cases of radiation in which the vagina is basically dead, if you will. You've got this very indurated tissue. I just don't think that the therapy is going to be efficacious because the tissue is in such bad shape. Short of that, we have treated a few patients that have had radiation for rectal carcinoma and for lymphoma, and assuming the tissue still has some pliability and is just atrophic, then I think those patients are fine. And I guess the other contraindication, in my opinion, would be an obvious mesh exposure.
This is a very interesting issue. I think that we have to distinguish between the clinical practice and trials. In trials, we could not use any ancillary treatment in order to avoid any misinterpretation of the results. But in clinical practice, sometimes we prescribe either lubricants or moisturizer cream. Some of our projects include the evaluation of either lubricants or local estrogen together with laser to see whether we can produce a synergistic effect. For PRP or hyaluronic acid injections, I know there are some units throughout the world that are exploring this possibility. I'm not an expert in that, but I would encourage these units to collect data and to produce hopefully some evidence.
Well, it depends on the quality of tissue. Of course, if it is tissue with moderate, mild atrophy, we can go deeper. We can reach something, let's say, that may range between 800 microns to 1 millimeter. If instead we are in the presence of severe atrophy, so way drier tissue, probably we are we cannot exceed a depth of around 500 to 600 microns. And hopefully this reply to this question. So again, thank you everybody. I hope you, let's say, enjoyed the webinar. I hope it was beneficial to everybody, and you learned something interesting, something that can help you continue this kind of challenge or mission that we have started, that is, again, to give the smile back to many women. Thank you very much.